Thank you, Mr. Chairman, and I want to thank my colleague, Mr. Clark, for sitting in for me today. I really appreciate that. And, Mr. Chairman, thank you as well for your service. We've had some great hearings in this subcommittee, and I really do appreciate your leadership. To our witnesses today, I have just a couple of questions. Dr. Mostashari, in your testimony, you indicate that any rulemaking includes some compromises between the aspirational goals we want to achieve and the reality of where the market is. Really important questions for us today, and I wonder if you could elaborate on that, and additionally what the impact on smaller or rural practices is if the expectations of meaningful use are set too high. Even in my own state of Maryland, we're a small state, 5.5 million people. A lot of people live in our metropolitan areas, but a lot of folks don't. And so even in a small state, you could have a two-tier system if we're not really careful about this.
Thank you, Ranking Member Edwards, for the question. It's absolutely true that one of the fundamental challenges we face in setting the meaningful use policy is this is an escalator that we want people to get on the escalator and continue to advance through the different stages. How fast up that escalator can we push? What's the rise and the run so that people don't fall off the escalator? Because we could set the standards very, very high, and only a few institutions, signal institutions across the country would be able to qualify for those standards, and we would not have succeeded in improving health and health care for all Americans. So it becomes really important for us to not set them so low that we're not changing the intrinsic capabilities and interoperability of the systems, but not set them so high that only a few can participate as well. The issue around rural providers and small practices are particularly important because historically those have been the kinds of providers who haven't had the resources to implement health IT effectively and have had consequently the lowest rates of adoption of EHRs. So when we took our Regional Extension Center program funded through HITECH, we said focus on the small practices, focus on the primary care providers, focus on the critical access hospitals, the rural health clinics, the community health centers. And I think it's in part due to these efforts that we've seen, for example, rural adoption of electronic health records now among office-based providers is 38%, higher than the national average of 34%. So it can be done, but we have to make sure that we set the rules appropriately and we provide them with the services they need to be able to get there.
I want to ask you a question that's somewhat related, and it's regarding the issue of upcoding. The New York Times recently profiled and wrote about some instances in which hospitals, particularly those Medicare providers, in using these IT systems actually were billing at much higher rates. And I have a question just about the design, whether it is that, and maybe NIST can comment on this too, we can have some way of testing these, the designs of IT systems so that we get a more intelligent design that might factor in the potential for abuse or the potential for upcoding when it doesn't result in a better patient outcome or better quality of care, so that we can actually guard against increases in cost in a system rather than seeing more efficiency in the system because of the implementation of the technology.
I would note that the article you mentioned examined trends in billing leading up to 2010, which actually predates the implementation of the EHR incentive program, which is moving electronic health records industry away from just being documentation and billing machines and towards things that, as Little commented, help us do in the new payment models of the future with accountable care and bundled payments and shared savings and so forth. That said, I want to assure you that HHS is taking the appropriate steps to investigate and correct any possible improper billing associated with EHRs. The Centers for Medicare and Medicaid Services is conducting a comprehensive review of potential improper billing through the use of electronic health records. We also plan to convene a summit of stakeholders to develop those potential policy and EHR design responses, as well as conduct a pilot of hospital audits using EHR technology functionality that support fraud enforcement and investigation so that EHRs are used as tools to combat fraud, not encourage it.
And is it possible, though, that in testing for standards that NIST actually might come up with a design that looked more intelligently at these systems so that you know, if there were system prompts or the software was coded in such a way that it would automatically kick out things that, you know, looking at an entire record might actually indicate that there was that upcoding going on as opposed to coding correctly for a given medical condition or circumstance.
So from this perspective, thank you for the question. Our role has really been in trying to ensure that we provide the best technical advice to get the best technical standards from the community with regard to interoperability, security, privacy, and so on. But that also includes usability, and one of the things that may be related to this issue is ensuring that the usability of these systems are testable in a way that might prevent, I would call, inadvertent mistaken coding or things of that nature where the usability of the system can help avoid those kinds of issues. With regard to the policy issue of trying to prevent intentional fraud, I think that would really kind of be beyond our scope. I'm not sure how we would contribute to that.
Thank you, Mr. Chairman.